Welcome again. Welcome to UCSF. This is one of our two main campuses, the Mission Bay campus, which has a brand new hospital across the street and it's tremendous biomedical research environment here. So we're sitting in the middle of UCSF, the Gladstone, Kaiser, just an incredible amount of innovation like we're cycling around us. And we're talking about vascular innovation today, which is perfect. Thank you all again for making the time to come to be with us here today, especially those who've traveled far and wide. Thank you to the staff who've done an amazing job setting us up for this today. I'm the CMO of Vascular Cures. I've been on the board for a while now, and this is always my favorite event that we do because it enables us to bring together colleagues from around the country to just brainstorm in an informal but productive way. People meet and start to collaborate that weren't collaborating before. We share ideas, and we always bring patients into the mix. So this is a really unique space that Vascular Cures fills. I don't think anybody else really does this exactly the way we're doing it today, and hopefully everybody finds it productive, goes home with new ideas, and comes back to us with some of those ideas around things that potentially can help to answer questions and fund some projects. When we were all thinking about what to do this year, my amigo, Manesh, cardiology amigo, and Isabel and I were brainstorming, and we came up with the thought around precision medicine. Just a little bit after that, ATVB got our idea, I guess. So we're definitely timely. I think all of us who inhabit this ecosystem of cardiovascular care, as patients, as providers, as industry, and as other stakeholders, are a little bit, waiting for this to happen for us. Obviously, in the cancer world, patients are getting identified with much more specific phenotypes of disease. Their treatments are getting targeted, and cardiovascular care offers lots of opportunities there, but it's going to be a little bit of a longer, I think, slog to get there for reasons that I think we'll talk about today. But I think the excitement is that with incredible advances in AI, in imaging, and in omics, that we're going to change the definitions of these diseases that we treat in different ways, and we're going to identify better treatments for patients that are going to be more effective, and also we're going to identify people at risk more quickly. Move this forward. So just to set the stage for the day, we have some amazing talks. We've picked people from around the country who are doing examples of different types of work that I think ultimately is going to be foundational for bringing precision medicine to the vascular world, whether it's from the basic science side or the genetic side or from the imaging or big data side. I think we all recognize that we see and treat patients with common vascular diseases like aneurysms and PAD and venous thromboembolism that we put these words on, but they're very complex, heterogeneous phenotypes. We have some patients who show up late in the disease course with very advanced presentations, or some patients that progress very quickly or progress not at all. And we have very limited tools to identify who those patients are. And I think every patient wants to know more about their prognosis, more about their options. And we do a lot of watching and waiting and seeing to see what happens. And I think that's the opportunity. The question really is, how can we more accurately define? I think this is the question really for the whole field in cardiovascular precision medicine. How can we change the lexicon? How can we better define subtypes, clinically, molecularly, or otherwise, that really are unique? And then how can we use those subtypings to improve the care, whether it's risk of progression, risk of developing an acute catastrophic event, or predict responses to treatment, or better identify patients or people who are not patients yet, who are at risk to become patients through tools that we can develop. Can we use so-called big data and AI to identify at-risk populations to make early interventions that might prevent them from becoming vascular patients or might change their course of disease? But the other challenge in all this is, how do we maintain a patient-centric approach? Because data is soulless. It doesn't tell you how people feel about how they're doing. It counts limbs and lives and hospitalizations and other things that can be measured, but it doesn't necessarily tell you how people are actually doing. And so how do we make sure that personalized medicine doesn't become impersonalized medicine as we do this? That's a big challenge in our field. So I think to do that effectively, we need to brainstorm together, and we need to include providers and patients as well as data scientists and omics scientists, so that we're all part of this ecosystem talking about how to make this work in a way that won't become so prescriptive that it might actually harm patients or individual patients. So that is a risk. So with that as a background, there has been a lot of recent thought going on around this in the cardiovascular sphere. Certainly folks in Boston, Joe Lascalzo and others have been at the front end of trying to lead us to rethink how we can do this in cardiovascular medicine, how we can use a variety of data sources, both clinical data, imaging data, and then multi-omics platforms to take a population with cardiovascular disease, be that coronary disease, PAD, or aneurysm, and subselect those people who really are different subtypes so that they're not all pooled together. By really what all this is about is clustering. How do we cluster people in the right way that allows us to measure how they're likely to do over time, and also how they might respond differently to different types of treatments? So I think the critical question in all this is really what are the definition of those clinically meaningful clusters? Clinically meaningful, genetically meaningful, proteomically meaningful. How do we integrate those clusters in the right way? Because if we don't do that and define those clusters properly, then we don't really know exactly what we're going to be getting on the other end. And so the challenges, which is nicely summarized on this paper from 2018 from Jane Leopold and Joe Lascalzo that was in Circulation Research, they summarized the challenges of this in all these four quadrants. There's the part about the actual omics, which is a big challenge in terms of cost as well as technologies and scalability. Talk about the issues with analyzing and managing this kind of data, both just the pure bioinformatics challenge, systems biology, but also the management and confidentiality of this data, how to make it both accessible, safe, but also portable and owned by the patient. And then actually, ultimately, to do implementation, the whole vascular ecosystem and the patient community need to be accepting of this. You can't just foist this upon them like the all-knowing, I think, from on high. So there's got to be education about what this means, what this data has, is being used for. There's got to be representation in how it's being done from all of the stakeholders we talked about. And ultimately, we may be redefining the actual medical encounter in terms of the kinds of information that we need to collect and also the samples that we may want to collect from people in order to get to this point of better care based on more precise science. And of course, that's a challenge because the medical encounters are already so intense and so stressed from many angles. But I think ultimately that is part of this mission. So with that as sort of just a background, I think these are some of the big themes that I see. And I'm looking to learn a lot today from all of you. I am very much excited about hearing some thoughts about how we as a group might be able to do some things in the vascular space that may be unique and may allow us to really accelerate this process.